Hello everybody and welcome to this second session of the Congress on the very controversial issue of opioid prescribing for non-cancer pain. There was a refresher course that many of you may have been to on Wednesday. We have three talks today. The first is going to be Kalso, who's going to talk about balancing benefits and harms and top tips for prescribers. Roger Naggs is going to talk to us about updated information on opioid-related harms and also emerging data on misuse of gabapentin and pregabalin, which is certainly a big issue in the UK and possibly elsewhere. And I'm going to talk about some more basic considerations supporting safe prescribing. We're going to take questions at the end of the session, so you'll have heard all three talks before we ask questions. You're strongly encouraged to use the EFIC app to ask the questions. Probably everybody's familiar with that now, but if you really can't use the app, there will be a microphone. So we start by welcoming Professor Kalso, who is known to everybody. She is Professor of Pain Research and Pain Management at the University of Helsinki and Director of the Multidisciplinary Pain Research, the Multidisciplinary Pain Clinic. And as we all know, she has been former president of IASP and is multiply endowed with many awards and illustrious other achievements. So,
Yes, good morning and welcome to this session on a very complicated topic which we are trying to make a bit more complicated for you. So first, the goals of efficacious pain management should lead to some decreases in pain perception and combined with a corresponding improvement in function, and both cognitive and physical functioning should be improved. Also, sleep should be improved and the quality of life should be improved. And in order to achieve that, more than 50% pain relief over the baseline is needed. Andrew Moore discussed this eloquently in the refresher course and has also written about this in many of the systematic reviews. So over 50% pain relief will result in these positive consequences to the patient: improvement in function, improvement in sleep, and improvement in quality of life. So this should be the goal. And also, the patient should be able to tolerate the adverse effects, because if the patient cannot take the drug, then it won't help the patient. So this is an old systematic review, but it shows individual studies using different doses of opioids compared with placebo in randomized and controlled settings in different conditions. The conditions range from neuroapthic pains to musculoskeletal pains and osteoarthritis pains. And now if we consider the new requirements for 50% pain relief, you see that the studies don't really meet this goal, considering also the strong positive response in the diabetic neuropathy pain, which is the only one that exceeds the 50% pain relief. And also the studies were fairly short, only a few weeks of duration. There have been several other systematic reviews and meta-analyses after that. This is one in low back pain, which is perhaps one of the most common indications when you look at the use of opioids in chronic pain. The very recent excellent guidelines which were published in Lancet Neurology regarding the pharmacological management of neuropathic pain state that opioids should be used or considered as a third-line medication, and that there is moderate evidence for efficacy, but the main reason for these drugs being as a third-line alternative is because of the adverse effect profile. So the patients should not only achieve enough pain relief and improvement of quality of life, functioning and sleep, but they should also be able to take the drugs. And adverse effects are a main problem with opioids. This is one study that was published in the a few years ago, and it shows that opioids are related to several adverse effects, but most of these adverse effects can either be treated or some tolerance develops to them apart from constipation, or the patients decide that these adverse effects are not worth tolerating because of inadequate pain relief. And actually, up to 50% of patients withdraw in randomized and controlled trials on opioids due to adverse effects or insufficient analgesia. Now, next, I would like to discuss a very fresh review that was published in Annals of Internal Medicine, which looked at the effectiveness and risks of long-term opioid therapy of chronic pain. And the conclusion of this review was that evidence is insufficient to determine the effectiveness of long-term opioid therapy for improving chronic pain and function, and that evidence supports a dose-dependent risk for serious harms. And I will shortly describe the results. So first of all, no study of opioid therapy compared with no opioid therapy evaluated long-term, and long-term was defined as lasting for more than a year, outcomes related to pain, function, quality of life, opioid abuse or addiction. There is good and fair quality observational studies that suggest that opioid therapy for chronic pain is associated with the following risks. And now these are the risks, are really the complicated ones and the reason why we are here today. So the risk for overdose is so that 256 patients out of 100,000 have problems with overdoses. Opioid abuse in primary care varies from 0.7 to 8% depending on the dose, and also the dependence varies from 3 to 26% depending on the initial dose in primary care. In pain clinics, the incidence of misuse varies from 8 to 16%, addiction from 2 to 14%, and aberrant drug-related behavior from 6 to 37%. Other risks and adverse events related to long-term use of opioids have also appeared from these observational studies, and these include fractures. And so in patients who use opioids, epidemiological studies suggest a 6% rate, and in non-opioid users, 4%. Also, the risk for myocardial infarction is increased, and markers of sexual dysfunction, particularly with high doses. An older study from Copenhagen, which has produced many excellent studies related to the efficacy and safety of long-term opioid use, suggests that patients who are on opioids show lower quality of life. This is the bottommost line, compared with patients who have pain but who do not take opioids. And the line at the top refers to patients, to the control group. So patients who are on long-term opioids, at least in this cohort, did not show improved quality of life, which should be the goal. Now, another Scandinavian study, which was published last year in Pain, used the databases and they performed a population-based pharmacoepidemiological study, and they wanted to identify what kind of patients end up having long-term opioid use and in combination to chronic pain. So the original study population was nearly 46 individuals, and more than 14,000 patients had chronic non-cancer pain, and persistent opioid use was identified in about 3% of the patients. And then the researchers looked at the factors that were related to an individual having the combination of chronic pain and persistent opioid use. And so these individuals had at the baseline higher prevalence of smoking. They performed less recreational physical activity. They used more drugs. They used or received more benzodiazepines. They reported higher levels of anxiety and depression, and they had a higher CADE score compared with people not reporting chronic non-cancer pain. And at this stage, I would like to remind you that the endogenous opioid system controls many different physiological functions. And in addition to pain and analgesia, they also control mood, behavior, stress, social status, and mental illness. So it's not surprising that the combination of mood disorders and chronic pain may complicate the prescription of opioids. And those who are interested in basic research and more confirmation about the role of opioid receptors in mood disorders, I recommend this very interesting study by Brigitte Kiefer and Dr. Lutz, who have studied the role of each opioid receptor in various mood disorders. So this, in a way, it was to be expected that when opioids are used more liberally, there will also be complications due to the fact that opioids do control mood and mental disorders. And interestingly so, Vanya Apkarian's, one of the many exciting studies that Vanya Apkarian's group has produced deals with how the representation of back pain shifts from its being acute and engaging mainly the nociceptive circuits to the emotional circuits when pain becomes chronic. So chronic pain of many years' duration has a very important emotional representation in the brain. And therefore, it is not surprising that the mood effects of opioids should be considered when prescribing opioids. This figure is from a study by Pasik and Kirsch, and it sort of tries to describe the various populations and how prescription opioid users are really a heterogeneous population. So there are patients who are adherent, those who are chemical copers, those who are substance users, and those who are addicted. And we really should aim in using opioids only in these patients. If we need to use opioids for very good reasons in these patients, then that should be done carefully and taking the responsibility of a comprehensive care. So even though from the very early on it was known that certain patients are at a higher risk at a higher risk, and various guidelines were published. Yet statistics suggest that patients who have these risk factors, they are younger, have anxiety, depression, or previous substance or drug abuse, they end up having the highest doses and the longest duration of therapy. I think this may indicate that this group of patients with whom we have the greatest difficulties in finding the adequate therapies or dealing with the patient's demands regarding opioids to solve the problems. So safe opioid prescribing relies on proper risk stratification and accommodation of that risk into the treatment plan. So I will show soon the list of various guidelines, but they may be difficult to use in each individual patient. But Stephen Pasick has suggested a simple tool that clinicians could consider using in their clinical practice. And it's about the black box and being in or out of the box. So the black box refers to how the guidelines recommend that we should prescribe opioids, or how our peers whom we believe know how opioids should be prescribed do. And if you behave or your prescribing practices are not in the black box, then you should think again and reconsider. So first of all, the dose which was suggested first time when an upper dose for chronic opioid prescribing was proposed, it was 180 milligrams. Now it seems that based on the results, for example, that I just showed from the recent systematic review that was published in Annals of Medicine, the upper level is lower, and it's 120 milligrams of morphine equivalents. So cancer pain and perioperative pain, they are standard indications for opioids. Patients who have no active psychiatric problems or substance abuse, or who have limited contact with non-medical users. So these should be the safe candidates. And also older age is considered as a better patient group than young individuals. However, other complications that I mentioned in a previous slide, like a risk for myocardial infarction and fractures, still occur in these individuals. But if you go outside the box and consider these patients or higher doses of opioids, then you really should think whether this is the right way to go, or at least you should refer the patient to a multidisciplinary pain clinic for assessment. Now, these are some of the guidelines. There are more general guidelines, and they are frequently being updated. And there are also some specific guidelines for headache or neuropathic pain. And I just referred to the very recent ones from this year, which were published in the Lancet Neurology. Several screening instruments have been recommended, which are simple to use and which will identify at least the patients at the highest risk. Also, there are new tools which you can use if you consider that the patient really needs long-term opioid therapy. And this is combining not only the ordinary measures of cognitive behavioral therapy and physical therapy and other pain medications, but you can also take advantage of modern technology and use, for example, the internet-based therapies to enhance the compliance of the patients. And then the list of the top tips. I have 3 slides full of top tips, and the first one is that be updated on the evidence for efficacy and safety of long-term opioid use. So you need to know the evidence before you start prescribing opioids to patients. And also be able to communicate this evidence to the patients, both regarding efficacy and adverse events, and also these complicated adverse events that are related to mood disorders and tolerance and addiction and so forth. Usually short-term use, which is defined as less than 3 months, and moderate doses as defined as being less than 120 milligrams morphine equivalents per day, should enable other treatments to show efficacy. And once they have shown efficacy, then you can taper down the opioid therapy. Long-term therapy is seldom needed. In case it is, if you consider it is needed, consider carefully. Because the first assessment and decision to start is the most important one. Because it is very difficult to stop treatment, particularly in patients who are at high risk and who are overrepresented in this group. And also consider what component of the patient's suffering you will be treating. Is it pain or is it distress? And be aware of the honeymoon effect, with which I mean that at the beginning the patient feels well because anxiety disappears, life feels better, pain is less, and the positive feedback that you as a physician get may also have an impact on the choices that you made, whether to continue, whether to increase the dose, or whether to look for other alternatives. And then set goals with the patient. It is important that you do it together for the treatment, for its duration, for the outcomes. Some decrease of pain, improved sleep, function, and quality of life. And sometimes a mutual agreement is always needed, but a contract may also sometimes be necessary. If long-term therapy is planned and the patient has risk factors, then the assessment and primary follow-up should take place in a multidisciplinary pain clinic. And I would argue that not having the resources is not a good reason, because the consequences of complications will need even more resources. Opioids should not be used as the only therapy, combined with CBT and other approaches. Stay within the recommended doses unless there is a very good reason for deviation. Assess the outcomes regularly, and stopping opioid therapy may actually improve the patient's quality of life. Consider that as well. In some very rare cases, opioid therapy may be the last resort, and then you will be treating a patient who has both chronic pain and opioid dependence. It's always the physician who makes the decision to start opioid therapy, and it's the physician who also carries the responsibility, and therefore it's important to keep good records. Our guiding principle is not to harm the patient, and therefore it is essential to consider what will be the best for the patient in the long run, not just in a couple of weeks' time. Thank you.